One more person in, and then okay, I'm going to make just some general comments quickly, and then I'm going to turn it over to Dr. Arthur Nelson, for those of you who don't already know him, and he's going to do a general presentation. I'll make some comments. Dr. Schiff out in Seattle will make some comments, responses, and then we'll take questions. This is the ongoing series. Most of you know that. You've been ongoing with us for years now. We decided to do a general presentation again on more specifically how orgone therapy works. What is it? I've done some general overviews of orgone treatment and orgonomy, but we thought it would be interesting to have a number of practitioners talk about the actual and gets on record some of the actual sense of what the therapy is and what it does. And Dr. Nelson is highly qualified in the sense he's been working at this for many, many years. I won't say how many. That's up to him to say. Has written extensively on this. For those of you, anyone interested in his article on orgonomy, which appeared in the Encyclopedia of Psychiatry, was it?
No. It was a book. It was a book on many therapies.
That he wrote a number of years ago, which is an extremely, very, very succinct and effective presentation. I can get you copies of it, a Xerox copy. The other thing is that David Silver has kindly offered for anyone interested, when we finish this presentation, he has a copy of the Wilhelm Reich Museum's, the Infant Trust Fund's documentary on Reich. It's a short documentary, it runs about a half hour, I think, which he's willing to screen for everybody if you want to see it on the big screen afterwards. It's a worthwhile.
Who produced that?
The Reich Museum, the Trust Fund, and as you know, I'm not one to always be, to praise unduly, but it is a good, honest piece of work. In a decent presentation, and it's worth seeing, and you'll get a chance to see some fairly unique footage and photographs of Reich, and it's worth looking at if you have the time. And since David has Dr. David, so but we'll give you a doctorate for this morning.
Keep on the respect
for your contributions, or as Mel Brooks would say, you're a DACA. You're a DACA. Okay, so. Today will be how orgone therapy works on December 7th, about a month. We'll do...
a day that will live in infamy.
Oh, that's true. Interesting. That's right. We'll do my presentation on play in humans and other animals.
Play?
Play, P-L-A-Y. So come, and actually I realize this is an excellent setting. I'm going to do the lecture by the pinball machine next time, while I play pinball and present that. But and then we'll see what happens for the spring. Hopefully, we can encourage Dr. Nelson to come back and present on some other topic. He wrote extensively. He doesn't write that much lately, but he wrote extensively in the American College of Orgonomy's Journal of Orgonomic Journal of Orgonomy, and. Why don't I just turn it over to Dr. Nelson to present what he has prepared, and then I'll comment, and Dr. Schiff will respond, and we'll take it from there.
Okay. I've been at this for 37 years, so that's quite a while. I began way back when we were absolutely swamped. It was the heyday of orgone therapy. It was when Orson Bean, he shortly thereafter wrote his book, and that was in the 70s. I started around 65, 66, and we were unbelievably swamped with people who wanted the quick fix that Orson Bean was, at least he exaggerated a little bit in his book. But things have changed a lot, and I split off from the American College of Orgonomy about 5 or 6 years ago. Don't quote me, but I thought they were extraordinarily rigid. etc., etc. And that's why I really haven't written very much since Baker died. Baker died in '83. I got a book in my head. I don't know whether it'll ever come out. Anyway, the topic today is how orgone therapy works. Let's do some definitions first. Therapy, of course, is the treatment of disease, mental or physical. And orgone is the primal energy in the body recognized in many traditions. Qi in the Chinese tradition, prana in the Hindu tradition, and élan vital in the Western, the French thing. Now, let's go. I don't know how much all of you know, so I prepared some generalities, and it doesn't bore you any. Let's do a little history to clarify how Reich got to this energy concept. You know, as you know, he was the first analyst. He was rising in Freud's circle very much, and they had him the head of the clinic there. And he was the first one to get off from the back of the patient. The patient would lie down, and the analyst would stay in back of him. They would never face each other. Reich was the first one that started to face people. He got out of that position, and he began to see very fascinating things, along with psychological defenses. He began, like compliance or mistrust or arrogance or whatever the patient presented, or suffering or something, which we know as the character armor. The word armor was actually started by Reich, because he originally named it as a physical thing, a muscular armor, which we'll go into. But he saw that the people manifested physical manifestations along with their psychological productions. And he saw tensions in their face, he saw the shoulders high, he saw a lot of tension, and it indicated to him that this was a possible physical manifestation of all the emotions that were inside that he was trying to elicit in therapy. And he also saw that if there was a deep release emotionally with his analytic work, some of these physical things would just disappear. He wouldn't see them anymore. Anyway, and then with this physical kind of release that people had when they had the emotional release, they would also describe all kinds of physical sensations in the body, currents and other sensations. And this, you know, in those days they talked about psychic energy. And Reich was the first one. His intuition must have been unbelievable, because he intuited that there were physical manifestations of these emotional processes. And he coined instead of psychic energy, he thought that there was a physical energy involved. Now this resulted in a new paradigm, and that of what he called psychosomatic identity and antithesis. And we all know that symbol. Well, we'll get to that. Now, the analysts deal with the mind and the unconscious and repression, etc., all valid. Now, the medical practitioner deals with the body. And there's little rapprochement between them, except the recognition that emotions may influence physiology. This is still going on today. Now, Reich asked himself, what is the axis about which they both revolve? This somatic expression and the psychic, the emotional expression. And then he called this energy. The basis of it is energy. Now, in other words, he would say, on a deeper level of functioning, the energy function is the common denominator of both physical and mental function. Although peripherally, seemingly antithetical, body and mind, they are both aspects of a common energy function on a deeper level. And he named this energy, orgone energy, from organism and orgasm, both functions.
The Baker people.
If you didn't hear that, out in Seattle, there's a New York City horn just went off.
Yeah.
For quite a while.
All right, so they are both aspects of a common energy function on a deeper level, and you know the symbolism, the energy, and then the psyche and the soma, supposedly antithetical, but originating from an energy function. Thus, for example, repression and character disturbance for the analyst is the functional equivalent of muscular armor. You'd say functionally equivalent. Both being an aspect of the more fundamental disturbance of energy function. Now, at the time that he was working with people still in this basically analytic pose, he began to question why some people got through therapy very well and functioned very well and were seemingly very happy. And he found that for most people in that state, they had a very satisfactory sexual life. And he began to look at that. And he found that indeed people who began to let go of these emotional things, plus let go of these bodily expressions that they had, which indicated to him many things, they established a sexual life that was very satisfying. And he began to investigate that in terms of the energy function. And he began to, what we know now, have a concept of health, which I think we all know, which has to do with the ability to discharge energy fully, to be able to let it go, to be able to see that it isn't blocked, and to have what he called the healthy release, the orgasm. And then we get to the concept of what is health. And health, we can say, is the free movement of energy and the ability to fully discharge it in the sexual act. And the free movement of energy, which we can see, has a pulsatile and streaming quality. Now, what are the blocks to this free movement of energy? And this is where we get into therapy. And there are two aspects to therapy which were valid in those days and still are valid today. And that is the psychological structure of the human being, what he presents, his so-called character armor, his attitudes, his rationalizations, his irrational emotions, etc., etc. And along with that, we find that there's a bodily armoring, there's a physiological armoring, mostly in the musculature, but also in the breathing itself, which has to do with the musculature, and the perceptual apparatus, which has to do mainly with the brain. Now, why armor? There's been some speculation that armoring in the primitives had to do, at least in the development of human beings, had to do with the development of the brain and the abstract ability, and that if we can have an abstract ability, we get to the point where we can have free choice, and we can sometimes make the wrong choice. Human beings made the wrong choice. And then they can get all screwed up because of that. And then you get they say there's an economic explanation where the development of property can create all sorts of envy and all sorts of conflict between people. And then, of course, you get people like Velikovsky, who thought it had to do with this tremendous thing like a couple of millennia ago where there was a tremendous, what was it? A comet striking the Earth, and it scared the living hell out of human beings. And that was a concept of early armoring.
He relates it to armoring?
Yeah, yeah. And then, of course, the development, the concept of self-perception and the fact of the brain, that the brain can actually absorb an enormous amount of energy and screw you up because of it. You know, there are as many cells in the brain as there are people on this earth in one brain. 5 billion cells in the human head. And that can absorb an enormous amount of energy. It makes it easily to get hung up. And of course, in the infant, in the human infant, and I go for this more than the others, the human infant cannot tolerate any painful feelings. Misery, fear, anger, they cannot tolerate it. And it becomes repressed, you develop defenses against these feelings. I think, and that, from my point of view, neurosis, what we call neurosis, which is the armoring, which prevents the healthy flow of energy, neurosis is universal and inevitable. Has to be. Now, so there are armoring happens, and it seems to be inevitable. And armoring is complicated. It is longitudinal, what we call segmental, and it follows the old psychoanalytic paradigm, which we still consider valid, of the oral, anal, and genital phase of development, except that in orgonomy we've added another one, which I think is extraordinarily important, and as a matter of fact, I think is the main block of human beings, and that is the ocular apparatus, the perceptual apparatus. I think the two major blocks of humanity, the perceptual apparatus, we tend to space out from minimal to maximal, and we tend to live in our brain a lot. This is very common. And the other major block is that of respiration. We don't breathe. We hold the breathing. And this is understandable because as a child, what's that famous book called, Prisoner of Childhood? You're a prisoner. There is a famous book called Prisoner of Childhood, written by a child psychiatrist. And the child cannot go anywhere, so how does he deal with painful feelings from the adult world? He either spaces out, which numbs the feeling, or he stops breathing, which numbs the bad feeling. For instance, if you get frightened, the automatic response is, and if you get it chronically, you'll stay there. And it's a way, it numbs the feeling of fear. So the breathing and the perceptual apparatus are the two major armoring of human beings. And the perceptual one was not stressed very much in psychoanalytic, because they didn't say an ocular level, they said just oral, anal, and phallic. Now, I think you all know about oral phase of development, which has to do with nursing, which has to do with satisfaction, because in the child, that is the way that energy is discharged. Before the adult ability to discharge, which is through the sexual function, the child does it through the oral discharge. Have you ever seen a child in oral orgasm? In some babies, they'll nurse and nurse, and then you get a tremendous trembling all the way down. It's amazing to see. I haven't seen it too much, but occasionally you see it with a baby.
I've seen it numerous times. There's not only trembling and release, but afterwards, it follows exactly. Reich describes it also very early. He's probably one of the first people to describe it. It actually follows all the steps that one would describe in a human orgasm. Essentially, tension building up to a peak of incredible ferocity. It's just the whole body is like, and then there's this incredible release. And then when babies discharge, it's like.
And then you see the color.
A number of you, I know there are a couple of women here who nurse, so you must have experienced, and some of us were lucky enough to nurse, if you remember, it's unlikely.
And then the color. The baby gets all pink.
That's why babies are pink.
Yeah. Anyway, so in that situation, of course, if the nursing is unsatisfactory, you can get armoring in what we call the oral sphere. You can get tension in the jaw, and besides, of course, the first armoring is in the eyes, where the eyes can be a little dissociated. We get this dissociation, and then you can get armoring in the oral sphere. The throat gets tight, and the jaw gets tight, etc. And then, of course, the anal phase in the psychoanalytic tradition, where there's the toilet training, and if the toilet training is strict and rigid, the child can get rigid and defiant and spiteful and all those traits. And then, of course, you get to the genital, the phallic phase, where the interest becomes in the genital, and Reich talked about the importance of genital play. Now, the childhood sexuality is not like adult sexuality. There's no longing for intercourse, for penetration, or between the sexes, but there is genital play. And that, of course, makes a lot of parents crazy, not so much maybe nowadays, but 30, 40 years ago, parents got very anxious, and of course you get tremendous amounts of guilt about that, and then, of course, what the analysts talk about, which is still valid, is the whole resolution of the Oedipal complex, where the child is attracted to the parent of the opposite sex, and there is a competitiveness, say, in the male between the father and the son and the mother, etc., etc. In my view, from what I've seen over 35 years of practice, I think the pregenital blocks are much more important than these genital ones. This has been my experience. In other words, the ocular blocks and the traumas of pregenitality far outweigh this Oedipal thing, which I think is a lot easier to resolve, but the pregenital ones are the hardest ones. Now, the armor is complicated, and it has a facade. In other words, it's not only longitudinal, meaning segmental, that you get armoring in the various, the oral, the ocular, and in the chest with the breathing, and the diaphragm, which is a very important thing. The diaphragm splits the body into two segments, really. And the diaphragm holds enormously in a lot of people. Now, these segments, you get the physical manifestation of the armory. You get in the diaphragm, for instance, you get a tight diaphragm, you get paradoxical breathing. Instead of the diaphragm going up when you breathe out, some people you see the belly comes out, and that's a sign of armoring in the diaphragm. And when they get nausea, a lot of people, when you start them breathing, they'll get nausea, and that's very often a sign that the diaphragm is blocked, and it's holding back crying. Because when you sob, the diaphragm is jiggling. And very often that's held back and because of the diaphragmatic spasm. And you get all kinds of manifestations which you can see when you examine a patient. And then the armor is not only segmental, it's longitudinal, but it has a layering. The facade resembles the core. In other words, a lot of us try and be very nice on the facade, and that's to be very social, to be very acceptable. Underneath that is where all the crap is, you know, all the nastiness and all the envy and all the distorted emotions. And this is what comes out very often in human relationships. In human relationships, say man and woman relationship, the first year or so is wonderful, all the excitement, the sexual excitement. Then they get to know each other, and then they go under the facade, and all the distortions come out. And that's the test of a relationship. And you got a 50% divorce rate, so that's the test. And as I say, the other 50% aren't doing that red hot either. So that's...
Actually, the 50% that are divorcing are the ones that are usually, in some ways, a little healthier.
Yeah, the other ones usually cling. And as I remember Dr. Baker used to say, what's the basis of most relationships? I'd say, you don't mean love, Dr. Baker. He said, no, it's usually anger. He thought that a lot of people were angry and the fear of anger.
And the what?
The fear of anger that keeps a lot of people together, especially in the old days. Especially nowadays with the liberation of women in the last 30 years or so, where women can not be so financially dependent on men, they leave these relationships. They leave them. But of course, what they don't realize is why they got into them in the first place, where generally you find a lot of abuse. There's an enormous amount of abuse of women by men. Enormous. They say, even nowadays, 1 out of 4 women gets beaten regularly by a man. It's amazing, especially the older ones. And they tolerate it. Anyway. So, and then to get through this middle layer, we get to the core. Now, any emotion can be stuck in any segment. In other words, you can get fear in the eyes, you can get love in the eyes, you can get suspicion in the eyes. For instance, and you can get dullness in the eyes, and you can get anxiety in the eyes. For instance, I have people move the eyes side to side, and you can see in the side, you can see terror, you can see fear in the side, you can see suspicion. You see less front on. You see in the front on, you can see the anxiety and the deadness, the dissociation. But have them look to the side, and it brings out the other feelings that are there. And you can see, if you examine the person, you examine the muscular armor. You can feel armoring in every segment. You feel a tight jaw, and that usually holds back crying in the jaw. You feel the neck, and then right here at the occiput, there's an enormous amount of tension, and that goes along with the fear in the eyes. It's been my experience that the occipital tension. And the chest is very, very armored, and the diaphragm, if you see that paradoxical breathing, or even without that. So it's all over the place, and it can hold any emotion, mostly. The chest can hold anything. They say the diaphragmatic is mostly anger, but it could be an enormous amount of grief, etc., etc. Now, the armoring, the basic character structure is usually formed by the ages of 4 to 6. But as Reich said, the armor solidifies in adolescence, which he called a second surge of energy. And he felt that in that time that some people could break through, but not too many. And the adolescent sex drives a lot of people crazy, so there's an enormous amount of repression there too. Now, armoring was necessary. Neurosis was necessary in order to survive. Neurosis protected you from these feelings that you could not deal with, but at a price. Everything okay?
Are you still on the phone? Dan?
I'm here.
Okay.
Okay, sorry.
Okay. Now, therapy. And therapy is based on the energy concept and the psychosomatic identity and antithesis. We work on both sides of the equation, whereas the analysts work just with the mind, just with the feelings, if they can get to them. We work both on the body and on the feelings. Now, we ask the patient what the chief complaint is, What are they complaining about? And you can tell immediately from the person's responses a lot of their characterological armor. For instance, some of them say, "You're the doctor, you tell me," you know. And then some will hand you 14 pages of written pages of notes, and some will be confused and they don't know why they're here really. So you try and get a history also of their past functioning, of what their childhood was like, and sometimes it'll be obvious what caused the problem. My father used to beat me, my mother never paid any attention to me, but sometimes it's not as easy as that. Some people will say, "Oh, I had a very loving parents and my childhood was very good," and meanwhile they're depressed as hell, and you know they really don't. They have repressed an enormous amount of what bothers them. And then you put them on the couch after you get the history and the complaints, and you can see how they function. Some people get anxious, some people get very suspicious, some people are confused, and some people are totally dead. And you examine, so you're getting an indication of what's going on. You examine the segments. Some people can't move their eyes very well. Some people can't even sigh. They have trouble sighing. And some people, of course, have very, very difficulty in breathing. They barely breathe. Now, all to ascertain the diagnosis. We want to know a diagnosis. The function of the diagnosis gives us clues to the treatment and also clues to their dynamics and what to expect. For instance, if someone is very depressed and is emaciated, we know that there's a tremendous oral problem there. So the problem is mostly in the oral segment, and usually that's tied to the ocular segment, although not always. And if someone is a very macho guy and is very, very arrogant, and we know this is in the phallic stage, and he's a very angry guy, he's usually very angry at women and wants to get his revenge against women, basically, but he doesn't know that. He thinks he's the sweetest guy on earth. So these give us a clue as to dynamics and to what to look for. Now, we are looking for when the diagnosis gives us as a clue as to when in development the major problems started. The earlier the problems, the harder it is in therapy to get rid of them. And by whom? Who created most of the trauma, and how severe? Now, what we want to do is restore the free flow of energy and achieve what we call orgastic potency. Now, we want to dissolve the armor, and that is to get out the bound-up emotions, usually from the past. To get the bound-up emotions means to get the energy flowing, to get the energy, the stuck energy. Now, we do this by increasing the inner push, what we call the inner push. For instance, the breathing will create a charge, and that creates movement internally. And sometimes you get someone to breathe, and they'll suddenly start to sob and cry for apparently no reason, because they've been holding it by not breathing. Not breathing holds in feeling. And sometimes you get, for instance, if I see people with their shoulders like that, I remember tweaking somebody on the shoulders, an enormous amount of rage came out. Enormous amount of rage. Just for little things like that. And we want to attack the armor from without. And some people are very unarmored physically. And a lot of them usually have ocular armor, and there's very little you can do in terms of external approach, except work the eyes with the flashlight. We usually do that. I usually have them, if they're really dissociated, a thing to do is to get them, first of all, the famous book by Alice Miller called Thou Shalt Not Be Aware. That is the perceptual apparatus, and that is one of the, as I said before, one of the main blocks of human beings. So the way, and the reason we're not aware is we've repressed. We're dissociated. Okay? Now, one of the ways to be able to make people aware that they are dissociated, especially if it's not minimal, is to have them look at a dot on the ceiling. Be at the dot with minimal thought. I mean, that's boring as hell, but it's amazing how it can make the patients aware of their dissociation, of the fact that they float away, they go into Never Never Land. Now, the other way is, besides the physical approach, is the character analytic to make someone aware of what's going on by questioning their particular stance. Say, if you have a compliant person, you can say, "You're a nice guy, you're the best patient I ever had, you're ideal." But I don't believe a word of it. And then the patient says, "Well, you're not being fair, look how cooperative I am." And then you say, "I don't believe a word of it." And then he says, "Well, you don't understand me." And then he comes back with a dream the next week that I murdered you. And you're pissing me off. And anyway, these are one of the ways you can get to some of the character analytic stuff. Or why are you so sad looking? And you just try and cope with a lot of the character things that you see on the couch. Now, we work from head down because the energy, it's the direction of flow. For instance, there are some therapies like the bioenergetic that work on the pelvis. The bioenergetic has given up the whole orgasm theory. They've given it up. And Lowen says, who's 80, I think. Lowen's almost 90. He recently said that therapy is a failure. Therapy has been a failure because patients are too difficult. Patients are too fucked up. Not that we don't know enough, but the patients are too fucked up. They've given up, long ago they gave up the orgasm principle. All right? So what they do is that they work on the pelvis first. And that, of course, will screw things up terribly. Because if you open up the pelvis first, the blocks above it will never let go. Because then it becomes the super armoring of the orgasm reflex.
They become more ferocious.
Yeah, become more ferocious. Anyway, but what we want to do is loosen up the blocks from the head, make sure we can open up the segments, and then go down, and be careful because as you go down, sometimes the upper one will come back. And so you have to be very aware of what the patient's all about and what he's telling you, etc., etc. Now, you can get breakthroughs of emotion, which is what we want, to get those infantile feelings, the feelings that make one exaggerate now. For instance, I'm very convinced after all these years that 80% of all the negative emotions that someone feels, and that is either fear, misery, or anger, that 80%, when it's provoked by something, usually by road rage or by a partner, like your lover will make you miserable at times, whatever. I'm convinced that 80% is irrational and comes from the past. It's triggering off past feelings in you. There's always a kernel of truth in it, but it's mostly from the past, and most people are not aware of that. They blame it all on the partner, and that's, of course, part of the 50% divorce rate. Because they blame all their misery and all their anger and all their stuff on the partner. So what we want to do is get this stuff out, this old stuff. Now, what happens is that we want to break down the armor segmentally and go down, and then you begin to see things happening. You begin to, when you know that you're effective, you begin to see physiological things happening. People begin to report tingling. People begin to report all kinds of sensations. And then what happens is you begin to get a involuntary movements in the body. You begin to get sometimes twitching, and then of course what we look for is what we call the orgasm reflex, which is the first sign of a general loosening of the body. And that is an involuntary tilting of the pelvis, plus the shoulders coming forward on the exhale. And this happens when most of the armor loosens up. And along with it, you may get what we call pre-orgastic anxiety. You begin to get falling dreams, and that is a sign that you're approaching the end of therapy, which unfortunately is not easy to come by. And we don't know why, really. We don't know why. Is that first of all, we don't know enough. For instance, I'll give you an example. Many years ago, I had a patient who was referred to me by his minister. The minister was a patient of mine. And he was, I would diagnose as a phallic character, a mild phallic character. And he was not aware of therapy too much, only he trusted the minister. And he was having trouble with his wife, and he had separated from his wife. And it was a kind of a so-so relationship. And I had him, didn't say a word for him. I had him in 10 sessions. First session, he breathed, and he began to get a little tingling. I said, second session he came, he began to get tingling, and also, you know, the so-called hyperventilation syndrome, which is not really hyperventilation. Hyperventilation is because people can't tolerate the increased oxygen because their breathing has been so repressed all their lives. So his lips would go up like that, he'd twitch a little, and the third session he'd say, "Oh, I'm feeling a little funny feelings going down." Fourth session, the same thing. Fifth session, he began to involuntarily, he says, what's going on? He said, the sixth session, he said to me, "My goodness," he says, "I feel very lively. I'm walking down the street and I'm bouncing." Seventh session, he says, "Women are looking at me in the street." He says, eighth session, he says, "I found a new girlfriend." Ninth session, he says to me, "My God," he says, "I have never had such an experience in my life." And he related to me an experience where his sexuality was healthy sexuality. 10th session, he says, "I don't need you anymore." He says, "Thank you, this is very nice, bye." And he had apparently been cured. I didn't say a word. Now, I told this to Baker. He says, "Well, this is what Reich always," he says, "this is what Reich always wanted from therapy. But we don't know enough. We don't know why this happens and why a lot of people are so recalcitrant." But anyway, hey, this is it, and the hour's up, right? Next week, we got to
go on.
Now, any questions on how you go?
Let's ask Dr. Schiff, do you want to make some comments, or do you want me to make some comments and then you, or how do you want to?
Fine if you want to go first.
Okay. Well, just a few things. One is on this last description is, that we don't know why. I mean, I think we do know why to some extent, that it's not why it's not that easy and why it's difficult to find situations like that. I would say probably two things. One is that most therapists can't tolerate staying quiet that long, and just bear with and be comfortable with the patient and trust the patient. I think there's often a failure on the part of the therapist to be able to tolerate that kind of quiet, just patient relationship. Another thing is in line with that, I made some notes of just little comments. I found the presentation excellent and just to the point. But I think also the therapy session, both in my own personal experience as a patient as well as doing treatment, is often very boring. I mean, in terms of the actual, presence of just being there and doing it,
Well, I find that depends on the character of the patient, Harry.
And the
Ocular patients bore me.
Yeah.
Very ocular.
Yeah. Yeah, I agree. But what I think, what I'm saying by that, I'm not so much saying that because it's boring, it's bad. I mean, I think what happens is that there's a process that one has to go through, and that, for instance, with Reich, we know people often misunderstand this. They think he was impatient. Reich would only work, as long as he felt it was necessary with any given patient. So you'd come in. Sometimes it would be 10 minutes. And he'd say, "Okay, see you next week. I did what we have to do."
2 hours.
Sometimes 2 hours.
Right.
So the result is, but what happened is, I remember talking with Dr. Sobey, is that we've gotten to this thing as patients are paying. They're expecting their 45 minutes or 50 minutes, whatever you set your time at. And if you don't get that time, you say, "Well, what's going on here? I didn't get everything." And if you ask a patient, usually, if a patient can breathe for 45 minutes and really just flow, they shouldn't be there. So you got 45 minutes, a half hour, 45 minutes, an hour, in which you have to sort of fill the time, although often it's only 10 minutes, 15 minutes in terms of what's really going on. So I think there's a tendency to often, not really see what the patient is doing. There's a lot of counter-transfer, what we would call traditionally counter-transferential issues. I think also the problem is, I was struck with in this last description with the fact that Reich says a number of places, and I remember when I was studying with Dr. Sobey and talking with Dr. Rothenberg, that the end phase in orgone therapy is one of the most dangerous phases. It's the most difficult. Because of this issue of pre-orgastic anxiety or orgasm anxiety that begins to present. And also because of the interesting phenomena that Reich describes, and he himself said he wasn't sure why it happened, but it did, it was consistent, and I've seen this, is impatience. That as the patient gets close to the final phase, or begins to really feel and establish deeper and deeper sensation, but when they're not quite there yet, a great impatience develops. And it's not an impatience that's unreasonable. Reich points that out. He says it's a reasonable impatience, but it's at that point you have to slow the patient down and say you can't jam it through. You can't break it through, because very often it goes back and the patient does what they've always traditionally do, is like, okay, especially the phallic, let me smash it through, get through it. And at that point, everything solidifies again, and you have to begin to move. So I think there's also, I think what we haven't addressed here today is the level of compulsion in the society. I don't think it's a failure of orgone, orgonomy or orgone theory, but I think often what we miss is that we grow up in and live our lives, no matter how healthy we can become or we are, in an incredibly, not just physically abusive in the sense of hitting and energetically abusive, compulsive society, so that in some sense, if you're healthier, or as one of the things that we as therapists have to face is that as we get our patients often to function better, they're going to experience greater restriction on their mobility, on their lives, and they're going to feel what it is they've been running away from for a great deal of their lives. That isn't to say you shouldn't do that, but I think you have to be aware, and you have to be, I think, very encouraging, very supportive of patients as they try to come to terms with increased mobility in their lives, both on a personal level as well as socially. And then, things like, you can get somebody who's in a terrible marriage to realize how much they long for a better and happier and more independent life, but realize that there's no physical way, economically or socially, for them to make that kind of decision without major penalties and major restrictions. And these things affect how the organism functions.
And I think, Harry, also there's much more stress in society these days.
Right.
Enormous amount of stress, financial stress, social stress, and also cultural stress.
Right.
And there's also a lot of tranquilization of people, and there's an enormous amount of drug use. There's an enormous amount of, for instance, marijuana use. And marijuana, I think, is deadly from an ergonomic point of view.
I think from a pulsatory point of view, it's absolutely
what I find with long-term marijuana users is the brain gets really, pardon my French, all fucked up, really. And here you get this tremendous tension with long-term marijuana users at the base of the skull, the occipital. And that has to do with the eye function. Because it's a tranquilizer. It's a way of detaching. And it gives them a little spurt of something or other that makes them feel good. But what a price.
And I think also what we're faced with is increasingly, and I notice this in younger parents having raised a 12-year-old and beginning to see it in my own child rearing, but also in the child rearing of patients of mine, that there's a tendency to, in a desire to compensate for how we perceived our own losses in childhood, to make everything okay for our children. I think that society has a tendency to try to make everything okay. I mean, in addition to all the abuse and all the real levels of physical abuse, there's also the flip side of that, which is the tendency to try to make everything okay for the child, to fix it quickly. And so what I find with younger kids today is often the sense of, well, fix it. You know, there's a problem. Why don't you just get it done? Get it fixed quickly. I don't want to. Why do I have to be uncomfortable? Why do I have to be bored? Why do I? And I say this to my daughter. And she's saying, "This is boring." I say, "Sometimes, sometimes things are boring." And there's a tendency in the society that says boredom is an evil. And it's not necessarily evil. I mean, I remember I was always struck by Dr. Sobey saying that at one point, all the other ergonomists were going out after a meeting, to socialize, and they were getting outright perceived that they were getting irritated with him because he wasn't going out with them to socialize, and he could sense that there were rumors going on that he's antisocial, he doesn't really want to be with them. And finally one night he said, I can't go with you guys, I'm really sorry, but you're all welcome to stay here with me. I'm going to be up for the next, 7 or 8 hours over the microscope, and I could use a lot of help and company. He said it's extremely tedious, and I would love to have other people to take care of some of this work for me and help me with the tedium of the next, 5 or 6 hours. And everyone said, well, we got to get going now, and and in a sense, I mean, we all romanticize, myself included, Reich's great discoveries, great work, and it was at the price of often hours and hours and hours of just tediously looking at a microscope, waiting for maybe one, small movement that would be carefully notated into the next movement, and that can also, it's like in hunting and gatherers. A good hunter is also someone who can sit and wait for hours until the right moment, and so we've lost that kind of flexibility in the organism. We have to have constant stimulation or tranquilization, and it has to be quick. So I think that's a particular problem that I was,
Well, look, the whole culture is based on diversion. Enormous amount of diversion.
Diversion, entertainment, diversion.
I mean, most people, do you know that the average American, I don't know, this was before the internet, the average American family looked at television 30 hours a week, 38 hours a week.
Right. Huge amount. Now they, if they don't watch television, they're on the net.
They're on the net.
People think I'm crazy because I just despise all that stuff.
Well, you are crazy. We're all crazy. That's why we're here.
Just because you despise all that stuff doesn't mean you're not crazy.
Yeah. Now, the other thing I wanted to comment on, which in terms of how orgone therapy works, I was very struck with, and caught when Dr. Nelson was talking about putting the patient on the couch. One of the things that I find in an initial examination of a patient is having the patient on the couch, just having them lie on the couch without telling them what to do. If you sit there and wait enough, you'll see almost everything, if you watch carefully, that you have to see about them, because just how somebody lies on a couch, and especially if we do orgone therapy, and I don't know what Dr. Nelson's position on this is, of course, one should be disrobed. And this is the big question in this society. You know, of course, when Reich had patients disrobed, it was very, very risque and questionable, led to a great deal of difficulty. So many orgone therapists have moved away from the use of disrobing or physical, you know, having the bodies naked. The reason for having the body naked, of course, is that that's where you're going to likely, you know, when the clothes are on and when things are covered, patients can cover. Remember, Dr. Sobey once gave a wonderful example. This is when he was working with Reich, and he had a patient. No matter what he did to look at this patient, he had them nude. He was watching them. He couldn't see anything. Could not find any place where the patient seemed to be armored. And he'd work with them, and he'd get some emotion, but the basic problems persisted. Reich saw him and watched him for a little while and pointed out to Sobey. He didn't move on it. He just pointed out to Sobey in the next session. He said, look at the guy's toes, particularly his little toe. It digs into the couch very, very tightly. So you go over to that toe and pull it and just pinch it. And so we did it, and the guy went ballistic. The whole organism began to just, I
got to tell you something. That reminded me. Quite a few years ago, I had a guy who was head of advertising for one of the big advertising agencies. He was the head of the department. He came in with his, what's the name of the most expensive suit in the world?
Armani.
Armani, and with a tie, and he was very soft-spoken, and I didn't quite understand what was disturbing him. And then I had him, those days we took the clothes off. I had him take his clothes off, and he became psychotic. Literally psychotic. He started talking about where the camera's looking at me in the wall. Where are those evil people that you're going to let out on me? I said, would you put your clothes on? Put his clothes on again. He became perfectly normal.
Clothes make the man.
It was unbelievable. And the point is about orgonomy now, I have, my referrals for orgonomic patients have fallen off tremendously in the last 10 years. And I get a lot of people for conventional therapy. And I try and introduce orgonomy to them. 2 out of 3 of them think I'm totally nuts. And they leave. Right? They mostly want a pill for the pain, right? Or that, and some of them I understand why they are terrified of lying down. They are very frightened. First of all, they lose control, which is the bit, especially in your phallic characters, in your vulnerable phallics. They feel they have lost their control over life, over things. And some people feel extraordinarily vulnerable under those circumstances. They don't know it, but they rationalize it and they think I'm crazy, and then that's it.
Yeah, I think this is all part of, this is a kind of, in terms of the theme, how orgone therapy works. This is not, and I remember Dr. Sobey and Dr. Rothenberg saying repeatedly, and I've talked with Dr. Nelson, saying, this is not easy. It's not, that, and I remember Sobey saying that Reich would say, look, and many times to a patient, and I've had to say that, you're going to go, he said that to the orgonomist, where you're going to go is going to be hard, and if you want to back out and you don't want to go, it's understandable. In one sense, in terms of what Dr. Nelson is saying, patients are not interested. In one sense, you could say, Lowen, our patients just, they're too difficult, or they're not cooperative, or they're not good patients. But Reich always said you never can blame the patient. And any failure in the therapy is a failure in the therapy. It's a failure in the therapist. Doesn't mean that the therapist is a bad therapist. It just means that they're not good enough. And that was Dr. Sobey's favorite phrase. You're good, but you're not that good.
Or sometimes there's a characterological clash.
But the problem is that this is hard stuff. The image in Ether Guard a Devil, or in The Murder of Christ, actually, and Reich says very clearly that the thing about, which I think applies to orgone therapy, is that if you go back to the Garden of Eden myth or core, the image is that once you're cast out of paradise, God puts angels at the entrance, which is the exit to, there with fiery swords. And if you ever were to find the entrance back in, you'd have to go through those angels with fiery swords, and it would be so excruciating. So Reich says that if you ever do find that moment, or you have a chance to get back in, most people will take one look at that or feel the first heat of those fiery swords and say, well, listen, it's miserable out here, but, I can make it,
Except for Muslims.
Muslims go in because they think that there's something on the other side.
72
virgins, right. And there's a reason that they're virgins.
Or
That was what I always... That's
72
what,
part is what intrigues me. Why 72?
I don't know. It's probably some numerical, reason. But what I always say is that they don't say that they're not going to. They don't say that when you get there they're going to stop being virgins. My image is that you get there and you're with 72 virgins who are going to remain virgins for eternity. Anyway, but I think that that's very important to understand that this is difficult work, both not just for the therapist, but also for patients. So I think there's that fits into all the different array of offers that are made for what can do the trick or do the quick fix. Just quickly to go through some things that I wanted to respond to. The inevitability of neurosis. It would feel that way, but I'm not sure whether, and that seems to me to be a very, very important question. Maybe we should even do a seminar on whether neurosis is inevitable in society. I think armoring, and that would be my last comment before I turn it over to Dr. Schiff to make some response, raise some questions. The issue of armoring, I think, is the way to phrase it. I think is, as I understand it, is the difference between armoring, which is a natural process, is an organismic, is a natural function. We armor in response to threat or danger, perceived or actual, and the difference between that and what we deal with once we're dealing with pathology is chronic armor, where it's become something that isn't flexible, that is no longer, as Reich would say, rational, biologically rational.
It's not dealing with current reality.
That's right. And so in other words, the classic image is you have a cat is lying on the floor in the sun, and you accidentally step on its tail. It armors, right, and it displays clear, range of defensiveness, preparation, physiological readiness to attack, to defend, or run, or take flight. All of this is rational. And then when you say, oh, sorry, and you pet it and you encourage it, and then what it does is it relaxes. It maybe at first still has a little suspicion and worry, but as soon as it's convinced that the threat no longer, and it's soothed, it basically relaxes again. That's a rational operation of armoring. The neurotic is like, well, listen, I'm not going to stop being this way, because as soon as I stop being this way, someone's going to step on me. So I'll stay this way to make sure it does. And then gradually that becomes the characteristic, both physical and behavioral way of being in the world, and that becomes very, very crucial to what we're seeing and dealing with when we begin, when we enter into the picture to do treatment, which is almost always long after the adolescent phase, which is why Reich, of course, became more and more interested in working with young children and pre-adolescents and adolescents, and the feeling also that the great interest in working with adolescents to create communities for adolescents. Of course, part of what we're living through now too, and we'll have to see how much of this falls by the wayside, is we're living in what I call the time, the period of the secondary layer, as Dr. Nelson described. You have the third layer, which is all the polite, proper law and order, proper structures. You got the secondary layer.
Thank God for that third layer, by the way.
Yeah, probably. And Reich also said that was the famous interaction with Reich, where he would evidently do these sort of Zen kind of things that all the therapists or the orgonomists came in, and he said, "So what do you guys think about the Catholic Church?" And of course, all these old, they were all even if they had given up their liberalness, they were still, oh, Catholics are terrible, horrible, most repressive institution in the world. And then Reich sort of smiled and said, I wouldn't want to live in a world without the Catholic Church. And well, what do you mean? He said, because they keep things basically under control, and without that, you're going to be dealing with the secondary layer, which is very wonderful to think about breaking through to the core, and all of us living like in paradise again, right? But if it's even possible to get back to the core, when you break through into the secondary layer, and we're living in a world of secondary layer, reality, you're going to deal with chaos. And while there might be a great deal of progress in that and freedom in that, the price of that progress is millions and millions of people falling by the wayside.
A lot of good people will
go down, right? So, and he was one of them, and there are others. So this is dynamite. This is very serious stuff. I mean, there's only a small group here, and we're talking sort of to the faithful, but it's genuinely stuff that has to inform not only what goes on in these little meetings, but has to inform then how we operate in the real world. And that's maybe the value of these kinds of ongoing interactions. And so the last thing I would then say would be that keep in mind in light of this that Reich, or ergonomic definition of health, which I think Dr. Nelson started out with, I think very appropriately, versus the traditional medical definition. The medical definition is you got a disease, you try to make the disease go away, okay? Get rid of it, cure it. The ergonomic definition of health is that disease is simply, not that you don't want to treat, a disease, but that you're never going to get, if you don't get at the core of the problem or the system that's producing the dysfunction, you're never really going to do more than keep following one disease to the next disease to the next disease, so that it becomes an issue of, the object is not to get the organism to be disease-free. A healthy organism will get sick at times, will have dysfunction. The idea is to maintain optimal pulsation in the organism, that the more the organism pulsates and is operative and is functional, then as diseases come, they can also be, responded to, and that the underlying reality is a continual sense of pulsatory health.
Yeah. But there's no such thing as total ideal health. Some
right. That's
idealize it,
Right. I think one of the great failures, and I won't say it's failure of Reich, but I think one of the great problems in orgonomy, maybe with all therapies, especially therapies that look to answer large questions about disease, function, health, biological origins and function, is that it plays into a kind of mysticism that I think we all share to one degree or another, which is that there is this ideal state of the orgasm. You're finally going to get the orgasm. I was struck by Dr. Nelson's account of this guy who finally said, I had this experience. I don't know what it was. I remember Dr. Sobey saying he had a patient who he'd worked with for a while who was always very focused on the orgasm, and then came in after one session and she described, I had this strangest sensation. I was making love with my partner the other night, and something happened that I've never experienced before. And he said, what was it? She said, well, it was hard to explain. It wasn't very dramatic, and it wasn't very unusual. It wasn't like a real orgasm. And then she proceeded to describe feeling very lovely, light, comfortable, and for days she was happy and she was not tense, a lot of the tension she'd been complaining about. And he said, well, you had an orgasm. She said, well, that's not an orgasm. No, orgasm is, and and I think there's a mystification of the orgasm as some master, and that in fact what the orgasm is just the body
letting go and feeling.
It's become a marketable product.
Right, that's right.
The people that get well describe their life as, well, all's well.
Right.
This is generally, no, not that there aren't any stresses or anything, but, and of course the sexual function is just feeling of letting go, and then during the sexual act is you become consciousness becomes clouded and you're floating, and it's very pleasurable. I mean, but there are no rockets going off.
Sometimes, maybe.
Yeah, but your perception of rockets going off is actually that by that time you're already coming back in and thinking about it. That's the problem. If it really happens, you're not thinking about it that much. It's later on you say, "Oh, that was wonderful." You know. But again, if Dr. Schiff is still there,
I'm still here.
okay, talk about patience.
Okay. Yeah, that is one. First of all, Dr. Nelson, I really found your talk. I enjoyed it a lot.
Well, thank you.
It was very, very simple, very direct, and got to so many of the points that I think need to be made. And
Talk into your phone if you can, and as loud as you can.
Okay, I will.
Okay.
Very clear.
Much better.
And it's always it's warming to me to hear that kind of account, and also to kind of have a sense of, hey, I've had some of these perceptions too, and I'm not alone in some of these ways of thinking. So I just want to comment a few things in terms of some of the stuff you said that fits with my observations as well. And in your account of the two areas that you spoke about where, if I understand right, the primary areas of armoring would be the ocular or perceptual apparati and breathing and respiration, diaphragmatic. And that's been my finding as well, that with most individuals, those become the areas that become most anchored, and also the areas that are most difficult to resolve. And, I wonder why that is, and I wonder if it's maybe because where the anchoring is neurologically and neurophysiologically, in terms of the extent of where perceptual armoring can become anchored in the various ways in which the brain functions, and how long that's functioning and the development of that functioning happens in the course of the first number of years of life. And with the respiratory function, in terms of how it is modulated pretty low down in terms of our central nervous system activity. And if that becomes patterned and disrupted very early in life, again, how hard it is to really change some of that.
I just let me quickly interrupt. I think that's a very, very important point that we ought to highlight is the relationship between respiration and central nervous system activity. And by central nervous system, I would also include, the cerebral function.
Right,
and
that
that
ANS, yes, or dynamic, yes.
That often we tend to think of, especially when talking in orgone therapy terms, that respiration is about getting the body open, but we don't really often address as clearly as I think we should an awareness, and I don't think we've investigated enough. Whether we have the means to investigate remains to be seen. The relationship between respiration and central nervous system function.
And I think in going along with that, it really...
A little louder, Ken.
In going along with that, it really speaks to what you were saying, Dr. Nelson, in terms of how the pregenital blocks are much more difficult and made to deal with, and also really are more pervasive and maybe make up more of what we encounter with most of our clients and maybe with ourselves. And how I think the ocular and very severe respiratory armoring are elements, and in fact the physical foundation of those pregenital blocks. And that also fits in terms of what we know in terms of neural and child neural development, and in terms of how the brain is developing, within the first 3 years of life, the rapid development of the brain, the rapid processes of integration of different areas of the brain. And depending upon the stimuli from the environment, which is primarily interpersonal stimuli, that is going to affect how these areas of the brain become organized and integrated. And for many of us and many individuals, that integration is disturbed in some way, and then that becomes reflected in an overall bioenergetic disturbance of energetic integration, which which I would say is, in a way, kind of what we're after in orgone therapy to, promote these kind of
A little louder.
promote this integration,
Right.
Either a micro or a macro level. So that really fits for me. The other thing I wanted to say, I really liked as well your statement about how the segmental, in the armoring, any emotion can be armored. And oftentimes, I don't know if those of you on the East Coast encounter this, but those of us on the West Coast encounter a lot of interaction with other body psychotherapies, or body therapies more than body psychotherapies, where there are ideas that the heart contains one emotion, and there's another emotion in the fourth chakra, and another emotion in the belly, and it becomes very mechanized. Whereas what you're saying is my experience as well. I mean, we can armor in any segment, and in any segment, we have the capacity to express all these different basic emotions. And if those basic emotions in that segment are being held back or need to be held back because they're linked with anxiety or shame, then it only makes sense that those emotions are going to be held in that segment. And those emotions emerge regardless. So even though one might say, well, you primarily get either rage or fear from the diaphragm, one might say that. On the other hand, when the diaphragm really lets go, you have enormous grief. And you have enormous sadness because, as was said, I mean, that becomes so important in terms of how biophysically we do cry. And so it can't be looked at mechanistically, and that's the point I take from what you're saying, Dr. Nelson. And
when the diaphragm lets go, you can also have incredible pleasure and joy too. Yeah, and often that's mixed. And it's always been fascinating to me that physiologically, crying and laughter are identical.
yes.
Except perceptually and emotionally they're not. And it's interesting where and how that shifts. We can often work with patients, and many of us have gone through this, where someone is laughing and say, okay, now try to change it to crying, and all of a sudden sobbing comes out. And the patient will say, well, where did that come from? And that my favorite question is always, where did that come from? And as if it has to be, and that ties in, I think, to what Dr. Nelson is saying, which is the assumption is that it has to come from someplace, and the place it has to come from is some thought or or cerebral, some idea. In other words, something happened to me, or there's some reason, there's some way of intellectually explaining where it comes from, and trying to get a patient to understand that sometimes when you start crying uncontrollably, where it's coming from is simply where it's coming from. It's there. It's in the organism, and it's releasing.
And the other thing that I wanted to say about the nervous system is that most blocking, most armoring, especially of the perceptual apparatus, but mostly of all armoring, which is, as I said before, based on fear or emotional pain, allows the sympathetic nervous system to dominate. Now, that's the one of contraction, and that's the one of the fight or flight thing, and it is not the one of expansion and pleasure. So this is what happens when we armor also. The sympathetic tends to dominate, and that also can lead to a lot of physiological illness, a lot of physical illness.
Yeah, because the sympathetic controls a lot of the physical apparatus and system. So as it contracts, it has to control it, because contraction becomes. That's why when we contract physically also, not just energetically. The parasympathetic is what really lets you go.
Right.
And that, of course, has to be protected by the sympathetic when it's under flight. And then at that point in the system, as Reich points out, the organism says to the parasympathetic, okay, lay back, I'll take over now. And then in a chronically armored individual, what's happened is they've become almost a completely sympathetic neurological organism who's constantly suspicious, guarded, watching, worried. I have a patient, fascinating patient recently, new patient, who as soon as he sits down and you watch him, and I actually had a chance to watch him walking in the street because he was coming to the office and I was out on the street for a minute, and with unobserved, and this is often very useful when you see people in other contexts, he has this constant look of worry. It's not a big look of worry. He just looks constantly distracted with worry. And clearly, you know, when I started working on that, it released an incredible amount of emotion. Mainly like, get away from me, leave me alone, stop bothering me. Why do you always bother me? Which I thought interesting. Okay, yeah.
Yes, just on that point about the sympathetic and parasympathetic, I think the point that I like from Reich's understanding, and is that it's the fact that we get locked in one position or another. It's the lack of the ability of the organism to pulsate between those two branches of the autonomic system that really then lead to the dysregulation, symptomatology in the organism. And not that one is better than the other. It is the regulation or the working together of those two parts of the pulsatory apparatus.
That's right.
Within us. And so without laboring this, because there's probably questions and stuff, the only other thing I want to say about my own, what I've been doing or what fascinates me in terms of some of the technique here is I often spend a lot of time with clients in terms of really looking at how they are with others in the world. Not only with me, but their interactions with others. And that stems from A, my understanding or my belief that so much of the armoring occurs from interpersonal interactions, and B, that the character is expressed within our interpersonal interactions and is being perpetuated by that. And third, that as one can become more aware of their own patterns, they have the possibility, and the emotional defenses within that, they have the possibility of changing that, undoing that, and then having different experiences in the world, which then can lead to the change in their functioning in the world. And it's, a client can have different experiences with us in the, quote, transference relationship or the interpersonal relationship with the therapist, but it is so crucial that they generalize that within the greater world. And I found that kind of exploration, which can be done not only in an abstract term or an abstract or discussion kind of way, but actually through evoking, through imagery or description, what happens interpersonally, and really looking at that and having those feelings come to the foreground is really important in a way that I find allows for this greater generalization and it allows for them to bring more of the benefits of therapy into their own life. So that's just an addition or just a kind of a style or kind of my way of dealing in some ways with some of the character analytic part of the therapy session that I've been finding is useful.
Yeah, just to dovetail on that, I would say that I've found over the years that the key word that I've come to use more and more is that patients have to go out and engage. I mean, we all have to. That's
engaged, yeah.
Engagement, and that you can get a patient to a point, or we can be as patients or as individuals clear about what we have to do. But you have to get out. Someone is suffering from depression, and you get them to realize that look, what you got to do is get out there, and even if you're miserable and even if you're in pain, you got to get out there and do some work, get involved, get into interpersonal situations. And the patient can sit there in the office for many, many sessions saying, yeah, I know, but I can't quite do it. And the fact of saying to them, you got to do it. This is like a prescription. If you don't do this, there's nothing to bring back in to work with.
Exactly. You have to help them engage, and you have to help them develop an awareness of the mode and way in which they do engage, prevent themselves from engaging.
You finished?
What I have to say?
And Dr. Nelson, I don't know if he has any comments. Maybe we'll take some questions.
Any questions?
A couple of years ago, there was a write-up in the Times, I think, a very large article.
Can you hear?
No, I cannot.
A couple of years ago, there was a major write-up in the Times about what they called the brain of the gut or brain of the diaphragm, that it had a thinking relationship to thinking process?
Well, there have been a number of articles recently in studies that show that, and I found that interesting from a mechanistic science point of view, is that what they're discovering is what Reich said years ago, is that the real experience in the world is not just a brain experience.
Yeah.
That the body thinks on all sorts of levels without necessarily going
cellular
to the brain.
memory.
Right.
Cellular memory.
And of course, when Reich said these kinds of things, or when we as orgonomists talk of such things, we're seen as, you know, if you say it in spiritual terms, you know, if you go into sort of a New Age frame, it's acceptable. But if you say it in that this is a scientific issue, you know, then it's seen as weird. But now, from a mechanistic science point of view, what they're discovering is, mainly because they start doing, as they study more and more of the neurosciences and more of the system, they discover that the brain as an organism is not adequate to describe all of what happens physiologically in the system. So they have to come up with, I think, as you said earlier, Dr. Nelson earlier, they come up with little bits and pieces to describe this experience and that experience, and this is what happens here, and this is what happens here. And so this is another one of these things where they're suddenly discovering, you know, there is this kind of, you know, process in which the body experiences itself without necessarily cerebral, you know, engagement. But again, we understand that clearly as just, you know, part of the organism's overall function.
What parts of your body remember different?
Well, I mean, it's, again, the organism engages with life, and it's what Reich called the expressive nature of life.
Regarding what you had said about the difficulty.
Can you hear out there?
Regarding what you said about the difficulty of living in. What's that?
Speak up, louder.
Regarding what you said about the difficulty of functioning in the world being so problematical, one of the things that I have found extremely useful is that Reich talks about a secular prayer that he made up. Apparently, he was sitting at Orgone with Peter and watching the sunset, and Peter was asking him if the sun will come up again tomorrow. And his secular prayer was, give me the energy to withstand the extreme ups and downs of a rich emotional life. And I felt that that was very descriptive. And so from that, since I read that, every time I'm going through total misery, I say to myself, I'm having a rich emotional life.
And I think in light of that, I think that the key is, and we've talked about this before when we've talked about the issue of pulsation, and that there's a tendency, particularly with, you know, what Dr. Rothenberg used to call the orgonomaniacs, you know, who see, you know, everything is orgasm, everything is expansion. Let's get on the road towards expansion, and poor contraction, you know, gets like the bad. It's like the bad child, you know, like get out of the room. That in fact, there is no expansion without contraction. It is they are just, in a sense, functionally identical. They are expressions of the total pulsatory function, and that contraction is an absolutely vital and necessary thing. It only becomes a problem
if it's chronic.
Right. That's right. Well, and by the way, one of the most fascinating cases that was presented on one of the Reich seminars that we listened to, absolutely fascinating situation. Dr. Sobey was one of his favorites. Is because expansion, when it becomes chronic, can become just as deadly. And one of the orgonomists brought into Reich a guy who, he said, I get him breathing, and the more he breathes, the looser he gets. He just, and by the end of a session, he's just like rubber on the couch. I can't figure out what's wrong, you know, and he looks to be totally so relaxed that it's beyond relaxed. And Reich met the guy and worked with him, and in fact this happened. And then Reich said, what you have here is basically a chronic expansion. And he said, and he used an absolutely brilliant image. He said, you know, we all know you take a piece of a rubber band and you pull it out, and it's very tense. You hold it out for a long enough time. What happens?
It relaxes.
It relaxes and it begins to sag. He said, what you have here is a guy who's developed, and this is why how tricky it is. You have here a guy who's developed a defense by the more you open it, you know, the more threatened he is, His organ, the more he relaxes. It's passive resistance. He relaxes so much that nothing affects him. And basically, he's a wet noodle, totally. And so that what Reich said, with a guy like this, what you have to do is you got to get him tense. You got to make him very scared and anxious, and of course, and I think it wasn't Dr. Sober's patient, it was one of Dr. Hammer's patients. They tried doing that, and the guy got scared, and he said, "To hell with you! I'm getting out of here. This is too much." And so we have to be really very aware that this is not. We do a lecture on how orgone therapy works. The final reality is, it's a arduous and serious, process. It's not a series of like Lowen gets you lie down, breathe 5 times, do this, move that, and you feel that. That's life.
Dr. Nelson, I wanted to tell you I love the last story you told about the guy bouncing down the street. But I really wonder about him. Like, did you hear anything later?
Never,
and I don't know if it's my resistance to believing that it's just the biology, and I think he needed to do more work, because why was his relationship before that messed up? But
I don't know.
don't you think he needed more work than 10 sessions?
Maybe not.
Maybe not.
Well, could you repeat the question?
Christine is asking whether the guy who...
Later on.
Right.
I don't know.
That's right.
But, my attitude there is no news is good news in that case.
Also, I think there are two distinctions here. There's the distinction between primary treatment of a very serious disorder or specific presenting problem and long-term intervention. Some patients will be in therapy for most of their lives because of the limitations of what can be accomplished and the kind of support they need. Other patients, I think we all, now for those of us who've done therapy long enough, we know, and for many of us who've been in therapy long enough, we know that there are different types of aspects of treatment. There's maintenance, there's direct intervention during a serious illness or serious dysfunction, or to address a serious dysfunction. And then there are some of my older patients who come back after years I haven't seen them, who come back in for what they call a tune-up, or they're doing quite well. Like, for instance, in principle, guy goes out, is finished with therapy after however many sessions he or she goes out, and you get a call 2-3 years later. Look, my wife just was diagnosed with, my mate was just diagnosed with breast cancer, and I'm really having a very hard time. Can I come back in and see you and be with you? Or they leave and they go into a very apparently successful and happy relationship. 5-6 years later, there are issues coming up and problems coming up. They're coming back. I need to be in treatment now. And one of my patients, a number of them said it, but one I think said it very, very, very well. That very often what the session can also involve after the initial specifics of treatment is a place that we go. And I don't think enough attention is often paid to that. That the therapy session is a place that one can go where it's your place. It's a place to be, to address the things that you need to address. And there's a sense of not only security, but there's a sense of it being yours. A place where you can do it. Now, what happened to this 10-patient guy remains to be seen, and I think Dr. Nelson's point, no news is good news, is true. But if he were to suddenly give Dr. Nelson a call now and say, "You remember me? I came in, and and now I'm having," and that would be appropriate also.
On the other hand, what's the difference if you hate your father as long as you're having a satisfying sex life?
Because eventually, if you can let the hatred of your father go, most of us get to the point where we say, right, so I hated him because he was a nice guy, he created that problem for me because he had a good life too. I mean, eventually you come to terms. I mean, the issues are really not specific to those places. That's where the failure of psychoanalysis has always been. The issues were that to see those things, to understand that that's where the problem started. How are you going to address it here and now, and how are you going to get to the point where it doesn't prevent you from having any kind of life?
But didn't Reich recommend fairly short-term therapy, and didn't even recommend to some of the doctors, if you can't solve it, kick the patient out?
No. Two things. That's a quote from Dr. Rayfield, which is an incorrect quote. I had arguments with him on that. Reich said specifically that if he could not cure a specific problem or a specific patient's problem in 20 sessions, that's the actual quote, he would not continue, he would discontinue therapy. He wouldn't kick the patient out, right? What he did consistently is that after 20 sessions, if he couldn't do it, he referred them to one of the other therapists who had more time and more interest and in Reich's terms, wanted to have make a living working with long-term chronic problems. For him, Reich, 20 sessions, meant that if he couldn't do it in 20 sessions, it was going to take much too long for him to continue.
He had better things to do.
And he felt he had, and I think
wasn't
clearly
his
did.
primary interest.
And it wasn't his primary interest. And this is, I had an argument with Dr. Baker on this. I mean, Dr. Rayfield. Dr. Ray, maybe Dr.
Rayfield didn't practice that. I mean,
Oh, yes, he did.
Much longer.
He
saw people much longer.
Well, sometimes, but numerous times, Dr. Rayfield, because I have patients that were specifically thrown out of treatment. They come in and he'd say, "You're impossible, out." And so, and I talked with Dr. Rayfield about that, and he said, no, Dr. Reich, he made that statement. Dr. Reich said, if you can't do it in 20 sessions, you should discontinue. Now, I'm sure he made exceptions, but the fact is, often what happened, I think, with many of the people who work with Reich is that with many of us, these things begin to become like folklore, and they become rigidly operative. I mean, I think that there are some patients. I can remember I had a girlfriend, years ago who had been in treatment, and she had a lot of problems even when I was with her, And I remember always thinking, I said to her finally, I said, "You've been in treatment in this orgone therapy." I wasn't involved with orgonomy that much yet. I said, "You've been in orgone therapy for all these years, and look at all these problems you still have." And she acknowledged that she had these problems, a lot of phobias and things. And she said, "You didn't know me before I was in orgone therapy. This is like light years. I mean, I wouldn't even be here now. I wouldn't even be able to have this much of a life." And her position was, if I have to be in orgone therapy for the rest of my life to keep myself functioning this much, it's eminently worth it. So I think that we have to look at these things realistically, and the fact, I mean, Dr. Nelson started with the point of Reich moving out from behind the couch, from the back of the couch. And the reason that people were in the back of the couch had nothing to do with therapeutic efficacy. It had to do with the fact that Freud could not, in his journals, he writes about the fact he could not stand facing his patients, and he also could not stand listening to them talk face on because he got tired, and he tended to doze. And if he sat behind, he writes this in his journal. If he sat behind the couch, he could close his eyes and listen to them drone on, and without having to, be confronted on this.
And yet, at the same time, the whole psychoanalytic tradition was based on that.
Right.
But at the same time, Freud would lend his patients money.
Right.
He would call them up when they were sick.
Right.
Say, "How's your cold? How's your flu?" Right. And he was very concerned.
He would take walks with them.
And he was a genius who discovered things that nobody ever thought of.
And he used physical manipulation of the body, which a lot of people don't know. That's right. And a lot of people don't know that Freud actively worked with manipulation of the head and the eyes, physically, hands-on, pressure on the head, work on the back of the head. And then about in 1920 or so, or a little bit earlier than that, gave it up and said, it's too unpredictable.
I had an interesting experience. When I was a psychiatric resident.
Jump in if you have anything to say.
Okay.
I was a psychiatrist. Does anyone know who Helen Kaplan was?
I do.
Helen Kaplan ran the sex clinic at Cornell. She was one of the first that started a clinic, a sexuality clinic. Anyway, when I was a resident way back in 1964 or something, she was my professor. And I once said, and I was doing therapy at the time, and I once said to her, "Dr. Kaplan," I said, "you know what I found?" I said, "Some people hold back their feelings in therapy. And I had a woman, and she was holding back her crying, and I gave her chest a little push, and she started." She said, "You did what?
You touch the patient?
I said, I made her breathe. I pushed down her. She said, why are you touching this patient? It was the last time I ever said anything to her. This was in 1964.
And
You can't touch anybody.
Right.
she's in the sexuality.
And she became the leader of sexuality. And of course, she was sleeping with all the residents.
Well, that was the classic.
She was married.
The classic, you know, these kind of things. The classic thing when if you read in Reich Speaks on Freud, they asked about, you know, the accusations that Reich was having, you know, sex with his patients, in which there is no recorded instance where he did that. He had relationships with former patients who he then, you know, his first wife had been initially a patient of his, Annie Pink, who became Annie Reich, but there was never an account. There has never been an account of Reich having active sexual contact with a patient during the active treatment.
The only one that admitted to it and was Carl Jung.
Yeah, well, Jung had numerous.
Carl had numerous patients.
Yeah, but also he admitted to it quite late in life, and many of the Jung's affairs were quite abusive too, very problematic. But interestingly, what Reich said when asked about this, he said, "You know, I never did." He said, "I got in trouble and I got identified with this because Reich was the one who said that it's perfectly appropriate to have feelings, and if they're real feelings, then you stop therapy, you wait an appropriate time, and you pursue it if it's still there and quite genuine." And he said, of course, the people who were attacking me, we all know, because it was a very small circle of both patients and therapists, we all know that the people who were most aggressively opposed to my views on this are the ones who were having sex with their patients during the sessions. And this was very true. And many of the people who were most active in their attacks on Reich were individuals who were later implicated in quite problematic, abusive patients. And Reich wasn't angry at them. He said the reason for that was because they weren't being honest. They weren't being clear about their own countertransferential and emotional feelings. And that this is what led to the problem. It wasn't about touching patients. The fear of touching patients was that was really an expression of a formalization of countertransferential issues about the same kind of countertransferential issues as patients had about being touched. Therapists have about touching, and it's the fact that everybody, what was it, Mel Brooks would say, everybody wants to touch it. Everybody wants to touch it. We all want to touch it, but we're all scared.
As Reich said, it was their dirty fantasy, not his.
That's right. Dr. Schiff?
I could, not exactly in this topic, but the one thing I did want to say before we end, and something that Dr. Nelson had said and had mentioned, which I quite agree on, is the idea that we just don't know enough yet.
Right.
And
Which nobody else
that can be
admits.
discouraging and exciting because there's the opportunity to keep learning.
Right, and Dr. Rothenberg always said that, is that we not only, when we talk about cancer, when we talk about sexuality, when we talk about orgone therapy, we don't know enough. The sad problem is we don't have the wherewithal, unless there's someone out there who has a large endowment that they're prepared to set up an institute. But short of having the wherewithal to do active research, we can at least keep the questions operative and anecdotally record and share our experiences, both as therapists, as well as patients, or as well as just writers or people out in the world. I mean, that's the other thing, and Reich was very, very good on that. In a sense, maybe to close off on how orgone therapy works. If it works correctly, it shouldn't be about just having orgone therapy. It should be something that a patient then carries, not as orgone therapy, but carries into their lives to engage in the way you live your life. One of the last things that Reich, I remember in a group discussion that was in the Annals of Orgonomic Functionalism, that magazine that they were publishing, Reich was talking about how you raise child rearing. And one of the doctors raised the problem that in his building, he would notice people raising their kids, and he didn't like the way they were raising his kids. And so shouldn't he go over to these people and tell them how to raise their children? And Reich said, no. He So what you should do is raise your own children and let people see if you do a better job. And they ask you, well, how come your kid is this way or that? We say, well, this is what I do. Not, you're doing the wrong thing. You shouldn't do it that way. And I think you got to carry it into your life. Dr. Nelson, we were talking about the Orgone accumulator over here that had belonged to Bill Steig's brother. And I suspect it was one of the accumulators that was originally used to treat William Steig, the artist, cartoonist, mother, who had been one of the cancer patients that Reich had treated. Steig, to this day, basically will continue to say in interviews, when they ask him, you're 90-some-odd years old, you're very successful, you do this, and what do you owe this to? He said, Orgone, the work of Wilhelm Reich, and the fact that I really got, people helped me, and Reich was a genius, and the work really informed me, and my books, and and not only that, I'm going to send you an Orgone accumulator, and he does. I knew a guy who used to make them for him. He would buy 5 or 6 and send them to people who never even knew what they were. We could say he's an extreme case, but he has no shame, no guilt about his engagement with this, and is very strong and very clear.
When they did that terrible review of the recent book of Reich's American Odyssey in the Times, Bill wrote a letter back, and he said that his mother had been given 2 months to live,
right,
and Reich treated her, and she had 20 years afterwards.
Yeah, well, I think it was actually 5.
He said 20.
But she lived a good long life afterwards, and more significantly, as he always points out, she lived those years with she was literally at death's door. She was ready to be put into a coffin. She couldn't get out of bed, and within a few months of treatment, she was out, walking and beginning to take care of her house again. So again, clearly they had a very good reason to feel very optimistic. But I think Steig, in his own way, was very, clearly connected to the work, and is an example of someone who let this work inform his way of being. That becomes, I think, the key. Well, do you have any last comment?
No, I think it's been said. Thank you very much.
Do you have anything that you want to? No? Okay.
Thank
Thank you again. If any of you want, I assume that David Silver's offer to screen the film on Reich still holds, so if you want to stick around to watch it, you're free. Any of you who owe me for today should pay me. I want to thank Dr. Nelson. Hopefully we'll get him back to do something else. And I want to thank Dr. Schiff for joining us again.
Thank you.
I want to thank you all for coming, and thank David Silver for his generous
I don't want to thank
No
David.
applause.
I don't want to thank David.